suggested to you in part one that chronic illness can include diseases from the category of infectious disease as well as the category of non-communicable disease, and we discussed in particular some of the misconceptions about non-communicable disease, and indeed it's the growing proportion of deaths from non-communicable disease that is making chronic disease more generally a much bigger problem for health and development globally. I suggested to you in terms of non-communicable disease that this set of conditions had received a lot less attention in development policy and practice, and in part two I'm going to start suggesting to you that there are different levels of response that one can envisage to non-communicable disease, and I'm going to discuss in more detail a broader perspective that argues that non-communicable disease is a matter for development attention and that suggests that we need a range of responses beyond a more narrow perception of the biomedical risk factors and interventions that have focused largely on individual level behavioural change. Now, if we just return now to thinking more narrowly about non-communicable disease, I suggested at the end of part one that non-communicable disease had received much less attention in terms of donor funding and emphasis. And this pie chart indicates that only 3% of global health aid has gone to non-communicable disease. So why am I making a case then that this is a problem for development attention? I described in part one that there are, in my view, certain misconceptions about non-communicable disease that have allowed others to argue that this is not the case, that non-communicable disease is not a development problem. There are some assumptions that are made that might not in fact be borne out by emerging epidemiological data, and in fact there is an inadequate amount of data about the burden of NCD in many parts of the world, but new data are emerging, and I would argue that some of this data, particularly for certain non-communicable diseases, in fact suggests that it's simplistic to assume that non-communicable disease in low and middle income countries only affects people in the higher wealth quintiles. Indeed, for some non-communicable disease, that is definitely not the case. And even in countries where the burden is higher, in higher wealth quintiles, according to national demographic surveys and so forth, it's very clear that there is still a significant burden also at lower wealth quintiles. And even if one was to assume that non-communicable disease in low and middle income countries, that emerging data are going to show that it is slightly wealthier people that are affected, it is important to realize that even amongst the emerging middle class globally, there are households that are close enough to poverty line incomes that contracting a non-communicable disease can still quite quickly push them into poverty and struggling to meet the costs of these illnesses in contexts where people pay out of pocket for illness. Another point just to make is that the assumption is often made that non-communicable diseases occur largely in urban populations, and of course I talked about urbanization as a bigger driver for non-communicable disease, but this emerging data are also suggesting that it's not an absent problem in rural areas in low and middle income countries. For example, the data on hypertension from South Africa is a good example, and that sometimes one might even have what one might call urban pockets in rural areas, and indeed in many contexts where you have rapid urbanization is often also associated with a circular pattern of migration back and forth from rural areas. So I would argue that considering the relationship between non-communicable disease and development and poverty more generally is a complex issue, and one where we need more evidence and we need to get away from quick assumptions about where this burden might lie. So let's now think a little bit more about this. Those that argue against this position bring forward a range of perspectives. There are donor agencies, for example, that would argue that non-communicable diseases are not matters for development attention because they are not diseases of poverty. And the argument there goes that non-communicable disease, in the opinion of these scholars, does not affect the poorest of the poor. In other words, this assumption that non-communicable disease occurs in people in the higher wealth quintiles in low and middle income countries. Another set of arguments against singling out non-communicable disease as a development issue relate to scholarship that raises concern about the big corporate interests that stand to gain from promoting non-communicable disease as a big global threat. And this is work by authors such as Stackler and Katz that looks in particular at the pharmaceutical industry and the food industry and the conflicts of interest here in promoting particular solutions to non-communicable disease. Now, they're very valid arguments to be made there, but in my view, they're also valid arguments to be made for the fact that there is evidence of development impact from the set of conditions. And indeed, Stackler also has argued that the fact that non-communicable disease was not part of Millennium Development Goals has in fact affected the ability of countries to meet other Millennium Development Goals. So the people that argue for the evidence of development impact really focus their argument on the fact that non-communicable disease causes premature mortality in many low and middle-income countries, in other words, in the economically active age group. And the second part of this argument relates to the strong connection between morbidity or chronic suffering from these conditions, disability, and the resultant poverty. So, for example, that link with poverty enables a broader link to human development more generally, and the evidence from many contexts does indicate how non-communicable disease can force many people or entrench them in poverty, particularly due to loss of income from economically active household members falling ill from non-communicable disease, but also in countries with weak health systems where people pay out of pocket for treatment. The event of being diagnosed with chronic illness can lead to catastrophic expenditures that can push households into poverty. A further aspect of the burden at the household level also relates to the care needs of people who are diagnosed with non-communicable disease. And this is, again, a complex area where other household members might have to leave their employment in order to care for someone with non-communicable disease, or alternatively, a household is paying large amounts for care in the absence of government social protection safety nets. So this really goes to underscore the fact that non-communicable disease can have a large impact at the household level in terms of finances, but the argument is also made at the level of the state. So I've presented to you an argument that, in my view, non-communicable disease is an issue for development attention, and that really leads us to the point of where to go in terms of future research, but also in terms of designing policy responses. And it's quite clear that to date, the policy responses that have been implemented have had a very strong public health focus and a strong reliance on the biomedical view that I presented to you in part one, which focuses on risk factors for developing non-communicable disease, the physiological factors at an individual level. And the logical conclusion that comes from this particular lens on the problem is that a main response would be education, early screening and detection, and motivating for individual behavioral change. Now, while I'm not arguing against these approaches at all, I'm going to suggest to you that considering the broader social, economic and also political drivers of non-communicable disease would suggest to me that a public health vision alone will not provide some of the policy answers to addressing the non-communicable disease problem in low and middle income countries in a sustainable way. And the big question really is whether it is possible and how it might be possible to mobilize political will in low and middle income countries to address these upstream socioeconomic drivers of non-communicable disease and not to only focus attention at the level of the individual. You remember in part one that I used the phrase the food environment, and I suggested to you, as Susan White has done, that non-communicable disease is not only about changes in lifestyle, but it's also about structural changes to people's conditions of life. And indeed, this perspective that suggests that we need a more comprehensive view of this problem and a set of policy responses that draw also on this broader political economy perspective, that draws on learning also from other development policy innovations. This perspective about conceptualizing the problem at multiple levels and understanding it as a development issue has also in fact been advocated by the WHO Margaret Chan has said we need a whole society approach. And also in September 2011, the United Nations actually held a summit on non-communicable disease and declared non-communicable disease a development problem. Now, I already have alluded that there are also some concerns about the interest groups that stand to gain from this framing, and those are some very valid arguments. But setting that aside for now, let's just think about why someone like Ban Ki-moon would make an argument that non-communicable disease is a development problem. And this goes back to the points I was making earlier about the link between poverty and non-communicable disease. So in Ban Ki-moon's speech at the UN summit, he stressed that the impact of non-communicable disease is particularly severe on poor people who do not have access to healthcare due to inadequate health systems, no free healthcare, and weak social care and social protection systems. So one way of thinking about the different possible entry points to addressing non-communicable disease from a policy perspective would be to see different levels of response along a triangle. So if we think about the top of the triangle, the argument really goes that non-communicable diseases are largely preventable if we can eliminate some of these major individual risk factors, such as tobacco use, unhealthy diets, physical inactivity, and harmful use of alcohol. And the focus here has been very much on promoting early screening and risk factor modification through individual behavioural change and lifestyle change. And from a policy point of view, the focus has been on early screening and detection of non-communicable disease, and also on getting access to low-cost drugs to try and shift some of these physiological factors. There's also been some evidence from population-level interventions to try and modify these risk factors, for example, through legislating about salt content in food, experimenting with substitutes for salt, legislation around tobacco control, and also even examples of countries trying to change the predominant kind of oil used for cooking products. And we'll talk a bit later about these kinds of legislative changes. But to conclude part two, what I really want to bring home is that from a development perspective, the point is not so much to think that it's possible to have a future where through individual behavioural change we can get rid of non-communicable disease or dramatically reduce the prevalence. For example, the WHO has a target of 25% reduction by 2025. Well, those are all noble aspirations. From a development perspective, we would say it's probably more realistic to think about the actual contexts in which people are going to be living and facing non-communicable disease, and start to ask questions about how we can reduce, in particular, early morbidity and mortality from non-communicable disease in low and middle income countries. In other words, to think also at the level of the effects on household poverty, but also more broadly about creating a more enabling environment, for example, through shifting the kind of food environment that people engage with, and thinking more broadly about the political economy of non-communicable disease and some of these structural factors that might make certain people more predisposed to developing these conditions. So this really involves thinking about policies that can address that lower segment of the policy triangle. And one way of doing this is to actually look at what existing policy innovation has occurred in countries facing a growing burden of non-communicable disease, and in particular in middle-income countries facing social inequality, health inequality, and also rapid social change. And in part three, I'm going to talk a bit about what kinds of policy innovations can be noted in these contexts. And the take-home message will really be that in order to address that bottom layer of the triangle, one really needs a much broader intersectoral collaboration than just focusing on public health responses. And we will talk a little bit about state-level interventions, how to get political will to address this problem, and what, from a governance perspective, could persuade a government that this is an important matter for health policy and indeed also for policy in other sectors. And we will talk a little bit about the relationship also between the food industry and the agricultural industry and the food environment and supply chains of food. And then in the second part of Part 3, we will focus also on the household level and look at some of the social protection suggestions for addressing non-communicable disease. And finally, we will talk about the health systems level, where I will return to the original title of this session and talk about a framework that considers chronic illness and chronic lifelong conditions more broadly.